Hi, this is Dr. Poole, and this is the first of 3 presentations on tumors of the ovary, which includes an overview or introduction to ovarian tumors, and then subsequently we'll focus on tumors of surface or Müllerian epithelium. The most common types of mass-like lesions encountered in the ovary are benign cysts and tumors, about 80% of ovarian tumors, and these typically occur in young women between 20 and 45 years of age. Now, we talked about benign ovarian cysts back in the course on sexuality and reproduction, and hinted at the fact that there are indeed tumors of the ovaries, and that's what I'm covering in these series of presentations. It's helpful to start off in terms of organizing the types of ovarian tumors in remembering that there are 3 main histologic compartments, and these are derived from the embryological origins of the ovary. First is the surface, also known as Müllerian epithelium. There's the germ cells, which give rise to eggs, and then the sex-cord stromal cells, which support the development of the ovum. Each compartment gives rise to a distinct series of tumors, and that's the foundation for the classification of ovarian tumors. There is also a group of tumors that defy classification, and then there are metastatic tumors to the ovary. Early diagnosis is the key to survival with ovarian cancer. Women diagnosed with local or early stage ovarian cancer have more than a 90% 5-year survival rate. Unfortunately, about 80% or 4 out of 5 of ovarian cancer patients are diagnosed with advanced disease that has spread throughout the abdominal cavity. Ovarian cancer accounts for just 2.5% of all cancer cases in women, but 5% of cancer deaths are because of the disease's low survival rate. In 2018, there was an estimated incidence of 22,240, but about 14,070 deaths in the U.S. Most primary ovarian neoplasms arise from the surface epithelium. There are multiple types of ovarian tumors, and some of the confusion with learning the pathology is that each of the surface epithelial tumors can be divided into benign, borderline, and malignant behaving categories. The vast majority of ovarian tumors are benign, and again, these mostly occur in younger women. But borderline tumors arise in slightly older ages, and malignant tumors are common in even older women, between the ages of 45 to 65 years. Some of the tumors that I'll discuss have some distinctive clinical features and are hormonally active, but most ovarian tumors are non-functional and tend to produce mild, clinically inapparent symptoms until they reach a large size. Common symptoms include abdominal pain and distension, urinary and GI tract symptoms due to local compression by the tumor, and vaginal bleeding. Again, malignant tumors have usually spread outside of the ovary by the time a diagnosis is made and are thus advanced stage. Metastatic tumors to the ovary are common, and most are derived from tumors of Müllerian origin, that is, the uterus, fallopian tube, or contralateral ovary. The most common extra-Müllerian tumors metastatic to the ovary are carcinomas of the breast and gastrointestinal tract. Classic examples of metastatic GI neoplasia to the ovary are called Krukenberg tumors. These are characterized by bilateral metastases that are composed of mucin-producing signet ring cancer cells and are most often gastric in origin. You can see these cells, which individually have this classic large intracytoplasmic vacuole containing mucin, which displaces the nucleus to the periphery of the cell, thus producing the signet ring appearance. The rest of this presentation will focus on tumors of surface epithelium. Most primary neoplasms of the ovary fall within this category. There's 4 major histologic types which are based upon the differentiation seen in the neoplastic epithelium: serous tumors, mucinous tumors, endometrioid tumors, and finally transitional or Brenner tumors. The critical morphologic hallmark for assigning a biological behavior to a tumor in this class of tumors of surface epithelium is based on the extent of epithelial proliferation. And this is what determines whether a tumor is predicted to behave in a benign manner when there's minimal epithelial proliferation, or a malignant manner when there's marked epithelial proliferation and evidence of stromal invasion. The borderline tumors fall in a gray area in which there's moderate epithelial proliferation, and this indicates an intermediate but generally low risk of malignancy. The benign tumors can be further classified based upon more of the gross component of the tumor, in which, when cystic area is predominant, the prefix cyst is attached to adenoma, indicating a benign neoplasm, so cystadenoma. When there's cystic and fibrous areas, these are called cystadenofibromas. And when they're predominantly fibrous with a minority of glandular or adenomatous component, these are called adenofibromas. So for example, you can have a serous cystadenofibroma or a serous cystadenoma. You get the idea. I'll start off with the most common tumors of surface epithelium, and these are serous tumors. As a group, I'll start off with the serous tumors, which are the most common tumors of surface epithelium. So serous ovarian tumors are lined by tall, columnar, ciliated cells and non-ciliated epithelial cells, and are filled with clear serous fluid. However, the designation of serous is not according to the type of fluid that's in the generally cystic neoplasm, but by the type of lining cell. So don't be confused by that. Serous carcinomas account for about 40% of all cancers of the ovary and are the most common malignant ovarian tumors. Risk factors for malignant serous tumors or serous carcinomas are incompletely understood, as are the risk factors for benign and borderline tumors, but it appears that nulliparity, family history, and heritable mutations play a role in tumor development. There is a higher frequency of carcinoma in women with low parity. As discussed in other areas of the course, inherited germline mutations in both BRCA1 and BRCA2 increase susceptibility to ovarian cancer. Serous ovarian carcinoma is divided into 2 major groups: low-grade or well-differentiated serous carcinoma and high-grade, moderately to poorly differentiated carcinoma. While this distinction is made based on the degree of nuclear atypia and correlates with patient survival, there are also some distinct molecular differences that are associated with this division. Low-grade serous carcinoma is associated with KRAS or BRAF mutations, while high-grade carcinomas are associated with P53 mutations. Note that mutations in both BRCA1 and BRCA2 increase susceptibility to ovarian cancer, and these mutations are associated with high-grade serous carcinomas. Some of the high-yield factoids that seem to show up on Step 1 exams are the incidence of bilaterality in surface epithelial ovarian tumors. In serous tumors, bilaterality is common and increases with increasing biologic malignant potential. So the highest incidence of bilaterality is seen in serous carcinomas. Benign serous tumors or serous cystadenomas are typically present as a unilocular, smooth, glistening cell cyst wall with or without small papillary projections. On the left you see the external surface, which is smooth and glistening, reflecting the light from the camera setup. And to the right you see the open cyst, which has been drained of fluid and has a white, smooth, glistening surface without solid nodules or papillary nests. The cut surface shows a recapitulation of what looks like fallopian tube epithelium. Remember, these are generally tall, columnar and ciliated, just like the normal epithelium of the fallopian tube. In areas which may have small papillae, there are stroma that's lined by columnar epithelium that is generally one cell layer thick and shows no mitotic activity. Borderline tumors grossly show more solid and papillary appearing areas, but are also generally composed of one or a few cysts. There's other areas of these borderline tumors which appear like serous cystadenomas. This is also reflected microscopically, where you have more complex papillae overall, and then epithelial proliferation, which is generally seen as these small tufts of cells showing nuclear stratification and more complex architectural complexity. Finally, serous carcinomas are more solid than they are cystic and show large nodular solid areas and frequently have areas of hemorrhage and necrosis. There's a yellowish area typical of necrosis, and these reddish areas show hemorrhage. And then this is reflected at the microscopic level as well. So serous carcinomas show evidence of stromal invasion and often display marked nuclear atypia with numerous mitoses and even atypical mitotic figures. Mucinous tumors are next up. These account for 20 to 25% of all ovarian neoplasms. So mucinous tumors are less common than serous tumors. They principally occur in middle adult life and are rare before puberty and after menopause. The vast majority are benign or borderline tumors. Mucinous carcinomas of the ovary are uncommon and account for only 3% of all ovarian cancers. Mutation of the KRAS proto-oncogene is a consistent genetic alteration in mucinous tumors that separates it from high-grade serous carcinoma. Mucinous tumors differ from serous tumors in a variety of different ways. The surface of the ovary is rarely involved, and only 5% of mucinous cystadenomas and mucinous carcinomas are bilateral. Mucinous carcinomas characteristically tend to produce larger cystic masses and have a multiloculated appearance, meaning that it has, instead of one or just a few cysts, multiple small cysts resembling a sponge. These also contain sticky gelatinous fluid, which is rich in glycoproteins, but again, the classification of these tumors is completely based on the type of the surface epithelium. So on histologic examination, benign mucinous tumors are characterized by a lining of tall columnar epithelial cells with abundant, apically oriented intracytoplasmic mucin. Mucinous carcinomas, on the other hand, demonstrate confluent glandular growth and evidence of expansile invasion. The tumor cells exhibit solid growth epithelial atypia and necrosis, but can still be demonstrated to contain intracytoplasmic mucin. A clinical condition referred to as pseudomyxoma peritonei is marked by extensive mucinous ascites, cystic epithelial implants on the peritoneal surfaces, adhesions, and frequent involvement of the ovaries. If extensive, this can result in intestinal obstruction and death. Although it was historically thought that the primary site in pseudomyxoma peritonei was ovarian, or the spread of primary ovarian mucinous neoplasms, more recently it's been appreciated that the primary tumor in almost all cases is extra-ovarian and usually appendiceal, and involvement of the ovaries and peritoneum is secondary. On the left, there's exposure of the abdomen in a patient with pseudomyxoma peritonei, and there's extensive tumor caking of the intra-abdominal cavity, and also involving the abdominal wall. The right shows characteristic microscopic features where you have mucinous tumor and usually abundant lakes of mucin, which sometimes contain floating clusters of mucinous neoplasm cells. The third category of surface epithelial tumors is endometrioid tumors. As a group, these are less common than serous or mucinous tumors. Most of these are endometrial carcinomas, which account for 10 to 15% of all ovarian cancers. Benign endometrioid tumors, usually endometrioid adenofibromas, and borderline endometrioid tumors also occur, but these are uncommon. Endometrioid tumors are distinguished from serous and mucinous carcinoma or tumors by the presence of tubular glands which resemble benign or malignant endometrium. About 15 to 20% of cases with endometrioid carcinoma coexist with endometriosis. The peak incidence of tumors associated with endometriosis, interestingly enough, occurs about a decade earlier than endometrioid carcinomas that are not associated with endometriosis. In addition, 15% to 30% of ovarian endometrioid carcinomas are accompanied by carcinoma of the endometrium, and the relatively good prognosis in such cases suggests that the two arise independently rather than by metastatic spread. Molecular studies have also found some striking similarities to endometrioid carcinoma. They both show relatively frequent alterations that increase the PI3K AKT pathway signaling, including mutations in PTEN, tumor suppressor gene, and mutations in mismatched DNA repair genes and in beta-catenin. Mutations in KRAS are also frequently present. The final category of surface epithelial ovarian tumors are transitional cell or Brenner tumors. These contain neoplastic epithelial cells resembling urothelium and are usually benign. They comprise about 10% of ovarian epithelial tumors. Transitional cell carcinomas of the ovary are very uncommon. Usually transitional cell tumors have a robust fibrous background, and the tumor nests resemble benign urothelium. It's an interesting reminder that Müllerian epithelium contains somewhere in its DNA the ability to differentiate into transitional type epithelium. If ovarian carcinoma extends through the capsule of the tumor and seeds the peritoneal cavity, massive ascites is common. and all serosal surfaces become diffusely seeded with small 1 to 5 millimeter nodules. Distant metastases may occur to liver, lungs, GI tract, and brain, and these are usually late recurrences after repeated episodes of ascites and local recurrence. Unfortunately, as mentioned before, ovarian carcinomas remain undiagnosed until they are large or have already shown extensive spread, and this accounts for their relatively poor 5 and 10-year survival rates compared to some other cancers that we've learned about in this course. Top priorities in the research around ovarian cancer focus on early diagnosis and prevention. Unfortunately, specific biomarkers for tumor antigens or tumor products that can be detected in the plasma have not been identified. There is one biomarker, CA125, that is present in more than 80% of patients and may be useful in following recurrent disease, but it's not a reliable marker, just as all of the other serum tumor markers that we've looked at, because it can be elevated in non-specific, non-neoplastic conditions that involve the peritoneum. So that's it for tumors of surface epithelium. Stay tuned for the next talk on germ cell tumors.